And it is my pleasure to welcome to the podium Hendricks Brown from Northwestern University. I'm going to ask you to refer to your biosketch materials for a more detailed introduction. And Hendricks is going to talk to us about evaluation interventions. Intervention evaluation. Thank you.
Thank you, Kimberly, and Peggy, and also Mark for inviting me to this session today. Okay, I find out how to do this. So good afternoon, everyone. I'm going to talk about the following kinds of things. What are we evaluating? Could a program work? Does a program work? And making a program work. So I'm going to try to keep a non-technical language in here, but to really get into what exactly are we intending to do. I'll talk about some of the science-driven programs and some of the models, particularly that might focus around prevention first, but it also an integration of treatment and prevention in a model that we have that we're exploring here in the city of Chicago. I'll talk about ways of doing evaluation designs. There's big evaluation designs, and then there's opportunities that we have not yet made use of for looking at cheaper and more effective interventions, particularly around those where communities and community-based organizations are really on the front line without a huge amount of funding to be able to work on. So those are the main things I'm going to talk about. I'll reach in and talk toward the end about a little bit of maybe about community boards, faith-based communities in Chicago and other areas. We haven't talked very much about that as well. And also a binational project that is just getting underway in the city of Chicago, where we have a group from Israel who is focused on trauma-based interventions and integrating it with a U.S. prevention system. So let me start off with the kinds of questions that people can ask about evaluation. Could a program work? We mean that under optimal conditions. Many people call that efficacy trials. Does a program work under realistic conditions? Those are fundamental issues that we need to know about. Not only just does it work or not, just a yes or no answer, but for whom it works. We are not going to get anywhere if we don't deal with health disparities in this area of looking at evaluation. And it has to be integrated early on in here in terms of who benefits, who might even be harmed by the same kind of intervention. And then a mechanism of how does it work is going to be critical for us to do improvements in here. The improvements can come in two different ways. One of them is to address issues which people have been calling implementation research. What are the factors to integrate at system levels to make sure that programs are effective? But we can also talk about improvements of programs, quality improvement programs on the ground. What are the local evaluations that you might need for one project that might not be relevant to other projects in there, but you need to tinker with it to make it work and be effective. Particularly, I wanted to mention this at the outset. We don't have a lot of time today, but I did want to say that the issues of evaluation are value-laden. They're certainly value-laden from a science perspective, but they also are from a community perspective. And there's a huge history of abuse of research evaluations, particularly in communities of color in the United States, but I would guess in other areas as well. And so we have to worry about those issues and be concerned about those from the very beginning. And also we're interested in cost, particularly for non-governmental organizations. So this is a picture that comes from the Institute of Medicine report in 2009 that laid out not only sort of these early stages of efficacy studies, that is understanding could a program work under optimal conditions, does a program work under more realistic conditions in here. But the biggest step in here is this upper box about implementation and dissemination studies. that have to do with adoption, implementation with fidelity, sustainability, scaling up, all the kinds of big issues that we really need to do if we're going to have a public health population-based impact. That's making a program work, okay? And the evaluations of those are a little bit different. We'll talk a little bit about it. I will talk some about randomized designs here, not exclusively about randomized designs, but in the scientific world, that seems to be the gold standard. Sometimes we can do good evaluations with randomized trials. Sometimes it's impractical or unethical to do those. But it's a place to start to think about what could we use for randomizations. And I wanted to push that idea a bit more than what we normally think of with the standard randomized controlled trial, because we need much more innovative kinds of designs of what we're using in here. This is an example which I use. It's a it is a example of John Snow's map of London. For those people who are not in epidemiology, this was the means restriction, as we've been talking about in here, about how to reduce cholera contamination through water. And what he did was he found and he took, in 1954, there were about 500 people who died from cholera. And he went in there and identified the source through water, took off the pump handle, and next year it was 0. So that's how big of effect it is that he had in there. Sometimes means restrictions, policy implications might have that kind of a big impact. But unfortunately, not many of them are around anymore. Most of the solutions we have are going to be not that big of an effect. And when we look at that, we need, and especially for these comparative low risk, low frequency outcomes of suicide and violent deaths and violence. I don't mean that derogatorily, and I meant that in terms of the frequency of those events occurring much less frequently than many of the other outcomes we have, we really have to have bigger studies or do something more sophisticated to try to address those issues. And randomized trials is a way of really helping us. Fortunately, we have a lot of randomized trials. So this is just an idea of what the Institute of Medicine counted, the number of trials they're moving on, and this was ended in 2007, but it's still growing exponentially in here. It's also across the life course, and I'm not going to spend any time on this, but it just does represent that if you started with intervention, say, in infancy or early childhood, that you could go and do long-term follow-ups of these interventions, preventive interventions, all the way into adulthood, which people have started to do. So here's a couple of mental health and violence prevention strategies that you might think about. I'm talking about programs. We spent the last time, most of the morning, talking about policies, and this is not about policy evaluations. It's sort of a different one, more about single programs and complementary programs that are integrated together. In prevention, here's a good strategy. Take early interventions that target both violence and mental health problems or drug abuse, and use those in youth as a way to do this one. The Good Behavior Game with my colleague Shepard Kellum leading that is one example of that. I'll just mention that later on in here. Another way of doing this one is to prevent the ongoing risk of suicide, particularly those with mental disorders already. Sources of Strength is one of the examples my colleague Peter Wyman at the University of Rochester has been doing. And treatment is a third way of looking at this one, taking trauma and addressing the issues of trauma and PTSD associated with violence exposure. The example that is going to be illustrated in here is the Natal program, which is one in Israel that has been focused around issues of wartime trauma. And the question is in that broad-based model that they've been working with for some 15 years or so, what could you learn in other settings as you try to transport that into other settings? So first of all, the message is that when you really go to some rigorous randomized trials, and you evaluate these programs, these kind of programs I just mentioned, these programs really do work. They do have impact. Here's some quick illustrations of this. This is not all of the data, but, and by the way, all of the references for the work that I've got are in the end of these slides, you're more than welcome to get these slides and take a look at those, but I'm not going to spend time on the references here. The Nurse-Family Partnership, and David Olds is doing that one, starts during pregnancy and has impact on child maltreatment. It doesn't have, as far as I know, the latest I've seen is not a beneficial effect yet on intimate partner violence. Randomized individual women to that, and then follows up with adolescent follow-up interviews of those kids 15 years later, for example. The evaluation cost of that project was expensive, and you'll see that the ones with the big dollar signs in there are ones that do follow-up interviews. It's pretty costly to do those things, and that's what NIH and CDC, IES, and other organizations in the United States have been funding in here for many of those. The Good Behavior Game has impact. It's a first grade intervention when the kids are, probably you guys can't see it on the things, but the kids are about this big when you start, and it has impact into young adulthood, 13 to 15 years later. That's big news that we have these things. So here's the things that it's significantly reduced: violence, adult and juvenile arrests, suicide attempts, alcohol, drug dependence disorders, and antisocial personality disorder as well. So that's big. Conduct disorder, whole range of opportunities for doing integrations of work in here by focusing on getting kids started in a successful way in first grade. That also has a fairly large amount of evaluation costs. The other three examples in here have much lower costs. And I think that's important to note in here because we still get some really good information. Peter Wyman has led the development of two major randomized trials on the QPR Gatekeeper Training Program and the Sources of Strength Suicide Prevention Program, focused around trying to get kids either into mental health referrals or to get them into more normative sections on dealing with coping with their stresses and problems and the like. What got randomized at that time was school and time. And I'll tell you about that because I think that's the kind of design that we should be thinking about and using in public health much more than we are doing it here. It was built on school district records and web surveys, so it was less costly than with the other ones. The Triple P program, Ron Prince has developed that came from Australia. It was evaluated in South Carolina in a randomized trial of counties, where some counties got this big, complicated 4-level intervention, some did not. And it used administrative records, so it really was a very, very inexpensive way of doing the evaluation. I urge people to think about those things. The Communities That Care is not a single program, but it's a comprehensive decision-making support process that communities go through to find out what their needs are, what their risk and protective factors are, to identify evidence-based programs to fit their needs and fit what they think that would fit with their communities. And that's also been evaluated and demonstrated impact on violence and drugs as well. Some programs that we're looking at in here, some are really major, have really major challenges. Here's one of the issues with the fact that the rate of the behavior that we're looking at really affects the size of the trial. And this is one, if you looked at suicide rates, you'll see that in adolescents, the rate is still pretty small comparatively to other groups, such as rural youth, have about 3 times the rate. Those with depressive symptoms and hospitalized attempters have much larger prevalences of suicide. I'm talking about completion of suicide in here. What this says is that you need, if you're going to go to a general population of adolescents, you need at least 1 million person years of risk. That means 1 million kids for 1 year or 100,000 kids for 10 years of follow-up. That's a lot of time in there, and that's a minimum on that one. So these are real challenges to look in our field, and it's one of the reasons why we haven't done as well in terms of moving forward in violence as we have before. So here's the message in here. Large trials are generally needed to evaluate the effectiveness on these low base rate outcomes, not just the ones we're talking about in here. AIDS is another one like that as well. But that doesn't stop us from going further and getting somewhere. So there's two stages that you might use for evaluating effectiveness in here. One of them is to look at an intermediary variable as opposed to the main outcome you might want to be looking at. Suicide attempts, for example, versus suicide is a good example of trying to do that one. The other way is to combine data across trials, which is what we've been very interested in doing. The data are out there from many studies if you can simply combine them together. And use judiciously administrative supplements from federal government to do an add-in on the follow-up studies, questions about suicide and violence, which we don't have. We just don't have those yet. And I think it's just strategically a very simple kind of thing to do, a very inexpensive approach for learning more about effectiveness of programs. So I'm going to move to this third level in here, talking about cheaper evaluation designs, especially with group-based interventions. It's often easier to evaluate, to do group-based randomized designs and get those into place versus individual level randomized designs in here. And many of the interventions we do are group-based anyway. We look at classrooms, for example, schools, counties, for example, and we can think about this as including things like rollout of programs for an entire country, for example, a new program. So I'll talk a little bit about that. The other issue that we can do is use administrative records when they exist. The Triple P example was the one I just gave in here, but it's not the only one. In the United States, there's a National Death Index that you can use to screen, to identify individuals over a long period of time, and the National Violent Death Reporting System as well. So here's an example where we can still use randomized designs in a way that it might be a little bit on the unusual side, but it's often something that communities are very interested in doing and are willing to be able to do. I'm calling those rollout designs. The idea is that we often roll out programs, and as you roll out programs, it gives you a unique, interesting opportunity to evaluate the effectiveness of that program. I also might want to add parenthetically, it also gives you a chance to really examine what the implementation strategy is as well for doing that one. We've used that by looking at randomly assigning schools when they receive a violence intervention. And I'll give you an example of this one. There's some technical words that people have used: dynamic waitlist design, stepped wedge design, are words in here that people have used, but I think even the wording, those wordings sort of push people away. And I think we need to use some simple rules about rollout designs. I think they're really useful for evaluating policies as we move into new programs. So here's what we did a number of years ago with Peter Wyman. We randomized when schools received a suicide gatekeeper training program. It was called QPR, which is one of the most common programs here in the United States, and the school district had already decided they were going to use QPR. And all we did was we came in at exactly the right time and talked with them about, well, let's see if we can randomly assign when schools get that, measure the school level of referrals, which is what our key outcome in here for suicide, before and after for all of the schools in that design. We had 32 schools altogether, and each quarter of a year we added additional schools to be tested in this one. So I'll give you an idea of this one. One of the things is we had to get onto the master calendar for the school district, so that it's not automatic to do this one, but I think it's an important piece in here. So this is what it looks like. The column in the middle is the traditional waitlisting design. So if you started, and this is in fact how we started and what we wrote the grant proposal initially to NIMH to do, is take 16 of those schools and give them initially the intervention the first year. And in the then use the remaining 16 schools to be in a waitlisted group that first year. But we'd already made a commitment to those 16 schools to go back in the next year and give them the intervention. So in the second year, all 32 schools had the intervention, and there was nobody in the control. What that meant was that the second year was not useful for evaluation at all. So if you look at the right side in here, this dynamic waitlist design, or this rollout design, takes 4 schools in the first quarter, puts them in the intervention, trains them, compares them to the 28 remaining ones in the waitlisted design. And then every quarter after that, you just move a number of those 4 into the next step. It's a pretty simple idea. Here's a couple of things that I have in terms of advantage on this one. First of all, the things that you need to do for this design, rollout means that the community already has decided that everybody is going to get the intervention. So that's a key piece to the whole thing. You need to add the following, that there has to be permission to do an evaluation and hold the design in place. You have to be able to randomly order the training of the groups and put that on a master schedule, and then also collect the number of outcome events at each interval of time for all groups. Okay, so a second point about this is that what's nice about this is everybody gets the intervention, but they also get it as quickly as they would normally do if this were just simply rolled out. So there's no cost associated with the delay in getting this to programs in here. It is fair because it's a flip of the coin, who gets it first. There is an advantage to those schools that get it first because they at least get something in place to start working with it. I mean, most of these school districts are desperate to find something that will work, and they're convinced that they need to do something now rather than wait, forever to try and do this one. The other part of it is that the schools who get it later could potentially get a payoff by waiting, because we might learn a little bit more about how to do it more effectively. This is an example that originally came from HIV prevention at community-based interventions. We've been promoting this one. It's now being used for some of the suicide prevention programs, but it also can be used for rollouts of policies, particularly at a national scale. And we really should be starting to think about using that in a very systematic manner. The ironic thing about this is that we found when we actually did this, you can get more complete and efficient training by doing it with much more precision with small numbers of schools rather than trying everybody at once. So it also happens to have good statistical power in this one. We published about that. It's certainly better than the waitlisted design, much more efficient in here. It's also less sensitive to external factors. Especially when the economy changes dramatically. You can still do this when you've got a lot more different steps in here that you can evaluate and put into your model in here. So we think it's useful for effectiveness. We've also done this on designs for implementation research as well. I'm not going to talk about that one, but the references are there. So I'm now going to go to the fourth section in here about what can communities do when you deliver programs. The message often you hear is that we can't afford or manage these large randomized trials for effectiveness. Well, certainly things like the waitlist design that we had, this rollout design, could be one of the ways in here. I also want to say that randomization is not always the right thing to do. I refer to people with this paper that West and Naiwa Dwan have written as one of the things to take a look at in here. We don't really have much time to really talk about it. But here's the other issue, is that I often hear the following, and I've heard it today or yesterday, we can't afford to do an evaluation of anything. All of the money we have has to go to services, okay? So here's sort of a message I wanted to do to try to counter that just a little bit. I'm not trying to tell anybody what to do and how to spend your money in here, but here's the situation. How many have heard the following statement? This is audience participation time. The path to heaven is paved by good intentions. How many people? Okay, we got about a third. How many people have heard this? The path to hell is paved by good intentions. I had about another third, and the remaining haven't heard of either, I guess. Which is it? Heaven. Well, I think it's really useful to think about this, about the path to hell is paved by good intentions, that intentions are not enough. We've had good intentions for a long time. Social work is built on that. Public health has been built on that. But we need to do better than have good intentions. We need to actually do work that's going to be successful and helpful for communities. That's our job. And understanding that and being able to demonstrate that what we think is working is actually working is really useful, because there's an awful lot of lessons about things that do not work in our field that we need to learn about. So I do think evaluation should be integral and an important piece of this one. Here's the second reason for it. Doing some evaluation forces some accountability in the whole process in here. I do think in terms of implementation science that, that this kind of idea of monitoring and feedback mechanisms is a really critical piece. You don't know whether you're doing it well enough yet, and you've got to get information about what the system is, how much change you're able to produce in here, and where it's going to go. So this is just kind of an illustration in here about a monitoring process and feedback to what institutions like schools, like state governments, which are generally hierarchical, state and local governments, and communities like the south side of Chicago need to do. And the arrow in the middle of that is the interaction between those. What is the integration of those kinds of elements in what we need to do? If we're not monitoring what's going on in those, what's the strength of those relationships, I think we probably don't have a good idea of what's going on, and we probably don't have any idea or a clue of how to sustain those programs over time. So let me go back and say, if you have very little money, what would you do? What kind of evaluations might be useful in here? Particularly if you want to know if you're doing good or doing better. I think there's a minimum kind of evaluation if you're using something that is at least evidence-based or evidence-informed programs. If you think that that's where it is, and somebody someplace has already got some information that that program does look like it works under certain circumstances, you should pay attention to something that is pretty easy to measure, participant engagement and program fidelity. So here's a situation in here. What you can measure for participant engagement in many of the programs is attendance and satisfaction. Those are pretty good analogies of whether or not you're connecting up with the target population to the level you want. And program fidelity, getting ratings associated with fidelity. In SAMHSA's National Registry, NREP, of prevention programs and practices, they do have measures and indications of how do you measure fidelity. I think we can do a lot more in terms of getting fidelity measures cheaper, but this is an important piece in here. This is a little picture that I think is useful. We've been thinking about this in terms of implementation of programs. On the left-hand side, we've got the community context, which is dominant and continual process. It evolves over time. The intervention agency and the intervention agent, such as a teacher, such as a parent, for example, is in here. And they have a program that we're trying to get them to do. We'd like to have that done with fidelity. We need some feedback to see how well they're doing. So that's that lower area. And then the target population has a participation level. And that needs to go back into, are we getting participation from the community? And if we're not, there's a problem with that. And we need to know that. And so this one gives you an idea of trying to keep that in target on that. Here's some real simple ideas. We haven't, I don't think we use these very much in our field, and here really comes from engineering, quality improvement strategies using statistical control charts. It's a little bit problematic if you're using low base rate conditions. Here's an example in a county that we used for looking at youth suicide deaths over a 10-year period. They're bouncing around from 0 to 9 or so. And there are very tiny numbers in here. We really couldn't tell whether that was in control or not, because it's just too much variability at that level. But we could do this one, is monitor one of the key hypothesized change factors. In gatekeeper training, we thought attitudes and self-reported behavior is one. You could pick one like self-efficacy, about taking on the gatekeeper role, which we think is really strongly impacted by our intervention in here, and do a control chart. That is, measure over time when you're doing repeated trainings of new people, how well are they measuring their self-efficacy? And you can see that there's a place in here, it looks like it's dropping over time. That would be the time to come back and intervene. Pretty simple idea, but we don't typically do this, and that's a useful kind of model. I'm going to skip some of these and talk a little bit about making a program work. The two areas in here is looking at implementation science, that is trying to get generalized knowledge of what a program works, and then also quality improvement, which is local evaluation. The re-aim program in here, the process in here, measuring 5 elements in here: reach into a community, what's the percent that you get, the effectiveness of the program, how much it can be adopted by new agencies, implemented with fidelity, and maintenance. All of those are going into whether you have a successful implementation or not. And those are measurable, and they should be useful and measurable. Lastly, I wanted to mention something about a violence-focused intervention that we're beginning to build in collaboration with a group on the south side of Chicago in Bronzeville. They've identified violence as a community's identified priority. That's the fundamental piece in there. And they've been really particularly interested in the trauma associated with victims and their families. They've taught us, we think of prevention as a fundamental piece of what we're doing in here, but they think of treatment as prevention. And the reason is because they want to think about that as reducing the amount of retribution that occurs in a gang-infested environment where there's a lot of violence going back and forth in here. The two groups that we've partnered with in here are Natal, which is looking at treatment, trauma treatment through faith-based organizations, and also the Communities that Care with David Hawkins and others around identifying prevention programs. The idea is to put them in complement to one another. We think we need to reach out to those organizations that have done this. It's organized by Pastor Harris at Bright Star Church, who has strong links to the mayor. Communities that Care and Natal are the ones, and then technical support from Northwestern Hospital and University of Chicago. This is something about what Natal's focus in here. It serves all of Israel. It has a multi-stage level with a lot of volunteers in there, but also backed up by 150 therapists to deal with trauma. It also looks at resilience in kids as well. And it's an integrated system. 160,000 people that they've served. I don't know how something like that works in the United States. It really is a comprehensive system, and that's why we're really deeply interested in learning about that one. So why would people in Bronzeville be interested in evaluating it here? One is quality improvement. I think that there is a fundamental need to say that communities deserve programs that work and do no harm. That's what our job is. And I think we have to do the evaluation and do that one. Also, it really allows us to do sustainability and exportability. So finally, in summary, there are diverse programs addressing mental health and violence in here. I've given a couple of examples for us to take a look at in here. There are, in fact, low-burden evaluation approaches as well, including the Rollout Randomized Design. So thank you very much.